if the baby has chest tubes, depending on what's going on with the baby, that's how many babies we would have in our assignment. Hey guys, welcome back to my channel. If you are new, my name is Quay. I am a NICU nurse. I have my BSN in nursing. So as you see for the title, today we're going to be talking about what it is that I do in the NICU. We are allowed to clock in 20 minutes before the hour. So I clock in around like 6:40. So after I come on the floor and I wash my hands, I grab a paper and we go to my first baby's room. The previous nurse and me, we go in the first baby's room like the order that she started in, and we give a report. We start with the baby's last name, the baby's first name, the baby's gestational age, the baby's corrected age. Gestational age is how old the baby was when it was born. The corrected age is how old the baby would be right now. So if the baby was born at 26 and 4, then the corrected age today will be like 33 and 4, like how many days old the baby is. And then we talk about the moms, and we talk about the delivery itself. We also talk about mom's social history, like drug abuse, is she positive for anything, abuse, things like that. And then we talk about psych, whether it's like a history of depression, anxiety. We go through how many times she's been pregnant. We go through how many babies are actually living. If the parents had like previous preemies in the NICU or previous children in the NICU, things like along that line that we get in report that is important to pass along. Also, we talk about the delivery itself. So why the NICU had to be there. You know, the mom was diabetic, whether the mom, had pre-E. There's a number of reasons why the NICU comes down to the deliveries or come up to the delivery. Was the baby a shoulder? Baby just premature, and that's why NICU needs to be there. Was the meconium? So we talk about the reasons why the NICU had to be at the delivery. We also talk about why the baby had to come down to the NICU. Because NICU is in a delivery does not mean that your baby, or that the baby will come down to the NICU. If it requires the baby to come down to the NICU, we'll make that call. Like if the baby's grunting, basically having difficulty breathing, needs oxygen, not a good color. There's just a lot of factors that play into why babies come down to the NICU. Did the baby come down on oxygen? Was it a cooling baby? The cooling babies is basically when there's trauma that happens during the delivery and the baby gets cooled down to prevent any further damage. We won't know how much damage was done until the baby is done cooling. I can make a video going more in depth with like the procedures and things like that we do in the NICU. Talk about if the baby's on oxygen, if the baby's on room air. We talk about if they had like any alarms, because when they're premature babies, they do alarm. They have B's and D's. The B's is when their heart rate drops. D's is when their oxygen drops. So sometimes they can have both at the same time, and that's when it's like really scary as well. What happened during those alarms? Did we have to like stem them, like to like get them back up? Did we have to suction them? Like what was happening? Was he like throwing up when that happened? Was he sleeping? So with medications, we talk about what they're on, we talk about when they're due, we pull up the order to make sure everything, of course, is correct on the medications that they're taking, the route, how much, what's running at the right rate, is it the right bag that's hung. We go through so much during report with each baby just to make sure that everything is correct when the new nurse is coming on. So after the medications, we then talk about the baby's feeds. We talk about how much the baby is taking, if they're eating at all. Some babies are in PO until we can figure out what's going on, until we can get that x-ray, until we can get that blood work back. Some babies are on formula, but we are trying to get more moms to breastfeed or use breast milk. Is beneficial to both mom and baby, but formula is also beneficial to the baby. We talk about the calorie. Is it 22 calories? Is it 20 calorie? Is it 24 calories? Is it 26 calories? Put babies on calories so that they can gain that weight. Some babies will have straight breast milk and they're not gaining any weight, so that's when we fortify the milk, and that gives that baby those calories and that fat that they need to grow. After we talk about the feeds, we talk about the baby's input and output. We talk about the baby's peeing or pooping. Some babies don't poop in like days. Other babies, they poop every single round. So it really just depends, but that is very important information. Like, I need to know my baby's not pooping. Basically go through all the important things about this baby so that when I'm caring for this baby, I know about this baby. we weigh babies' diapers who are on fluids, like lots of fluids. Want to make sure that they're having a lot of output and all the fluid just isn't like sticking on them. Like I only measure diapers if there's like mostly pee or just pee in there. So after we talk about the baby's output, we go over if the babies have any like diaper rashes. We use Desitin in our NICU, and we also use Vaseline. We don't use anything else. If the parents do not want Desitin used on their baby, then they can go over that with the doctors, and the doctors can okay if they can bring like A&D ointment or bring their own type of diaper cream, but that comes from the doctor. So I can make another video and really go in depth with every single thing that I do, but this video is the routine in the NICU though. So if you guys want that, comment down below and let me know like different videos that you want me to talk about. I'm gonna try to be more consistent in this YouTube. It's just so hard to like work and then like working all those days and then getting off. I just want to sleep. How I prioritize is if my baby, like I pick the baby that's more like the most unstable, and I go in there first and I assess that baby. So when I first go in my baby's room, after I wash my hands, I put my gloves on, and then I log into the computer. I scan the baby's IV band. I see what medications are due. I scan their milking. If they're on breast milk, we have to scan their milk to show that we gave that. If they're on formula, we just like chart that in there. Like there's nowhere to just like scan Similac or anything like that. We chart that in there, but breast milk has to be scanned. I'm also checking their bands to make sure that their bands match, and when the parents come in, I make sure that their bands match with the babies. They like just delivered like not like hours ago, and then they'll come down to the NICU to see their baby, and they'll walk in the wrong room. It is very easy to get lost in our NICU. It's very like difficult to get around. I get lost sometimes walking, so I make sure I check the bands to make sure that they have the right baby. That is very important. During my assessment, I start with a blood pressure. I put the blood pressure cuff around them. I try to get their blood pressure when they are the calmest. Sometimes they can be a little upset, and that can make their blood pressure go up, and that's an inaccurate blood pressure. So I want to get their blood pressure when they're as calm as possible. Their blood pressure, I listen to their lungs, I listen to their belly, I listen to their heart. A lot of the times, like I hear murmurs. You're going to hear some murmurs on babies, like they're premature for one. So murmurs are definitely common in the NICU. I listen to bowel sounds because a lot of my babies, their bellies are so huge, they're distended. Then feel their fontanelles. Their fontanelles is on like the top of their head. I feel the top one and the back one, and we have to chart if they're flat, if they're full. We need to feel those to make sure that they're not full. You want them to be flat, you want them to be soft. You don't want them to be like bulging or having a pulse or anything like that. The chart the sutures, if it's overlapping, if it's open separated, if their head's molded, if like we have to just basically chart like all the abnormals or normals on the baby, but we mostly are looking for abnormal. We are concerned in getting head ultrasounds. You're gonna have some swelling on the baby's head, especially if the mom was like pushing for a while. There's gonna be like some swelling on top of their head, which is molding. That's normal, that will go down. But you just want to assess that baby to make sure that there is nothing that is so abnormal that you need to call a doctor about right away. I change their diaper, I make sure that they're peeing, I make sure that they poop. If they didn't poop, I check to see when the last time they pooped, just to make sure they are pooping. The poop looks normal. My hands, I changed my gloves. As long as everything is okay regarding the vital signs and everything else, then I start feeding the baby. If the vital signs were not normal, then I would call the provider and then go from there. Like I'll call the provider for a high temperature or a low temperature. There's blood in their stool. Their lungs are like not symmetric. If I feel like maybe there might be a pneumo in the one lung because the sounds are diminished. If my baby's belly just looks really bad and I haven't had that baby, or if I had the baby and I notice that it's worse, then I will call the provider. I call the provider for any type of changes. It is just very important that we stay in contact and stay in communication with these providers so that we are giving the best care to our babies. So yes, once everything is okay during assessment, then I feed my baby. Whether the baby's PO fed or NG fed, which is a tube that goes down their nose or an OG that goes through their mouth. We do OGs if they have bubble CPAP in their nose. So if they're getting fed NG, then I just hang the feed by gravity. When you're feeding by bottle, you want to look at how they're feeding. Is their suck good? Are they taking a good amount, or are they struggling? So if they're needing like more, if their worker breath is more, trying to eat, or they having alarms while they're feeding. And the same thing for gravity feed. Like if you notice your baby is alarming after you hung that feed, then it could be a lot for our babies, and that's when we have a feeding pump. That's when we put the syringe on a pump and it administers to the baby like over an hour, over 2 hours, over 30 minutes, whatever the provider orders. Usually babies that are bottle feeding, they have a minimal requirement that they need to meet each round that I feed them. They need to be taking that amount because they go by their gestational age and then they go by their weight. So they calculate everything and they need to be taking that amount so that they can gain weight and grow. So yeah, those are the things you want to do while you're feeding. Every time I feed my babies, I have them like right in front of me, and you know, I'm bottle feeding them and I look at them. I make sure they're not turning colors. I make sure they're not like struggling. I make sure they don't need like a break. I stare at my baby the whole time they are feeding. I do not look everywhere else when I'm doing that. I pay attention because it's just very important. Like the NICU is very serious, and it's very important to catch those little details. Like it's not little, actually. It's really big details that can help with their stay in the NICU. So yeah, after I feed them, I put them back down. Either I swaddle them if they're in an open bed. They cannot be wrapped in an incubator. So in an incubator, I just make sure they are comfortable. Make sure they're not like pulling at things because they pull at so much stuff. And then I go in my next baby's room and I start the whole thing over. So after I wash my hands and walk out the room, I go into my next baby's room and do the same. We do this for 4 rounds. So our rounds start at 8 o'clock, 11 o'clock, 2 o'clock, and 5 o'clock. So it's every 3 hours, but we start the hour before. So for 8 o'clock round, we start at 7 o'clock. We typically have 3 babies that we take care of. They're not gonna give, like, I'm not gonna say they're not gonna give me a 3rd baby with an intubated baby, because I've had 3 babies with an intubated baby plenty of times, but they try not to. Usually we get 3 babies if it's just really busy in the NICU. If we are low on staff, we have rounds. So during rounds, all the providers and everybody that is caring for the baby, the attendings, the residents, the fellows, respiratory, and the nurse for that baby stands for the baby and do rounds. We used to have a lot more people come around during rounds, but because of COVID, they spaced everything out. So we no longer have like every single person in rounds. We just have like one of each person, if that makes sense. Like one doctor, one resident, one nurse, of course, one respiratory. In rounds, we talk about the change of care. So we increase babies' fees usually during rounds in the morning. Sometimes we either go up or down depending how they were doing on that amount of feed. So if they were doing good, we go up little by little. We don't just go from 10 cc's to 30. We'll go from 10 to 15 or 10 to 13. Like, we don't increase their feeds fast. But we do make changes during rounds. We talk about the care with the parents. The parents are usually there as well. Sometimes, if not, then they update the parents after rounds, and they'll call them for the changes on the baby's care. Whether we're taking them off of oxygen, giving them a try, or whether we're putting them back on oxygen because they alarm so many times overnight. That's when we talk about their care. We weigh our babies as well at night. We weigh our babies. We have bath days as well. Sunday and Wednesdays are our bath days. I can't see myself doing anything else. Definitely not adult. My next step is to just travel nurse. So this is my video on what it is that I do in the NICU. Please comment down below if I forgot anything, or if you want me to talk about anything else specifically. This was just supposed to be like what I do as a routine in the NICU. My lash appointment is later today. Don't judge me because they're barely hanging on. They are barely hanging on. Oh my God. And my next video will be a hair video. I will be taking these out. I've had these in for 3 months, guys. So I will be taking these out on camera. And I have a lot of new growth. So yeah, guys, please stay tuned. And if you want to see my hair video, just watch the next video after this.